to make the time. So welcome. My name is Shannon Burke. I'm the regional manager for the Central East Regional Cancer Program. We're very excited to have you with us today. And we have Dr. Audrey Lee, a radiation oncologist from the Durham Regional Cancer Center, presenting with us today. Dr. Lee is going to talk about PSA screening for prostate cancer. Dr. Lee has been working here with us at the Durham Regional Cancer Center since 2010. She completed her medical school and residency in radiation oncology at McMaster University in Hamilton, and she did a fellowship in gynae and prostate cancer at Princess Margaret Cancer Center. And she continues to specialize in both gynae and GU cancers like prostate cancer and skin cancer as well here at DRCC. She does brachytherapy, which is internal radiation for both gynae and prostate cancers, and comes to us with a wealth of knowledge that she's very excited to share with the group today. So thanks so much for being here, Audrey. There will be time for questions at the end for everyone. And yeah, I'll hand it over to you, Dr. Lee. Thank you so much.
Let's see if I can be a technological whiz today, shall we? Who knows? Who knows? Should practice this earlier. Hang on. Can everybody see that?
Looks great.
Awesome. And I'm going to be looking from the side because I have two printers, so two screens, so the camera does not go to my other screen. So this is a topic actually a little bit near and dear to my heart because that's how I managed to see a significant number of people in my practice. So there's been a lot of debate about PSA screening. So we're going to talk about yes or no, when and why my thoughts, my personal thoughts on the matter, I suppose, my evidence-based and somewhat expert thoughts on the matter. My full disclosure is that I'm a radiation oncologist who treats prostate cancer, so obviously I do have a vested interest in PSA screening. So these were the objectives that were listed for this talk today, and I'm going to instead-ish put my practical objectives, shall we? So let's talk a bit about risks and benefits of screening, whether it's always harm versus benefit, sort of the intended and unintended consequences, and what happens now and later when we decide to screen or not screen. You'll hear me talk a bit about myths and misconceptions with PSA screening and sort of the historical evolution of that, shall we say, and how important it is that we really take a Canadian context in these approaches to PSA screening. From a primary care perspective, can we do a shared approach to decision making when we talk about PSA screening? I firmly believe in Canada that we do smart screening and smart treatment, and therefore really we can mitigate some of the harms and benefits of screening or not screening. And then to focus on the fact that we really do have modern treatments now, that while there are side effects and complications to the treatments that we offer people, we have evolved. And so the radiation that is performed today is not the same radiation that was performed even 5 years ago or 10 years ago. And surgery, maybe to a lesser extent, is, but there's lots of stuff, surgery, robots, all these kind of things. So, some of the harms that we have, so-called from treatment, I think are mitigated by the advances in technology and skill and such. I don't think we need to dwell on this very much, but we all know that prostate cancer is the second most common male cancer under lung. And we still have a significant proportion of patients with prostate cancer. And unfortunately, many of them do die of prostate cancer. In Canada, there's less people, so we have less people dying, but there is also associated morbidity, side effects and complications with having prostate cancer, both in the locally advanced and early stage prostate cancer and then metastatic. And what we lack in many places in the world are access to this high quality, high precision, personalized prostate cancer care, which, we have places like here in Oshawa for this, but it's uncommon overall in North America, and obviously in other countries, completely non-existent. this is too much for me because I just know PSA exists, but it is a glycoprotein that we test in the blood, and it is almost always consistently expressed in all prostate cancers, although I would tell you in some lesser levels in specific cell types that we have. These are the 4 basic causes of elevated PSA, which we all know and love. And the PSA, like the free and total PSA ratio, help us distinguish people who have more a malignant cause of their elevated PSA. The problem with detection of prostate cancer is that it is not so symptomatic, and that we have early prostate cancer, which really you can't know or detect in any way except for with a PSA. My patients come to me and they're like, listen, I feel fine. I don't feel sick. How can I possibly have this diagnosis when I feel completely well and feel like I did, the day or whatever before I had my biopsy or my PSA done? Uncommonly, people come to get diagnosed with some urinary symptoms, but it is not specific, and it's relatively uncommon in the people that I interact with. Unfortunately, however, symptoms and signs of advanced metastatic prostate cancer are very variable. I have patients who otherwise feel fine and their PSA is 400 and their scans show metastatic disease everywhere. And I have people who are very debilitated by leg weakness or bone pain and sort of everything in between. So signs and symptoms are very difficult to help us point to what's going on with the patient in terms of prostate cancer. And you might see everything in that sort of continuum, honestly. That's what makes this all so challenging. So again, how do we deal with the in-between? There's such a huge spectrum of disease. You have asymptomatic, microscopic, well-behaved, low-risk prostate cancers, and then obviously the more aggressive, high-risk prostate cancers that are, potentially in lymph nodes and locally advanced, eating their way outside the prostate, and then not surprisingly spread elsewhere, and always potentially has consequences in terms of how people feel and then how long people lived for. So before a certain year, in the States that was 2012, and in Canada was 2014, there'd been a decline in both prostate cancer incidence as well as prostate cancer mortality. And we saw this for some time, according to these graphs, which was very encouraging. So that's mortality was kind of going down. And this kind of was before the impact of what happened next. So the US Preventive Task Force, Service Task Force, made a recommendation in 2008 not to screen gentlemen over the age of 75. And then in May of 2012, made a recommendation that there should be no PSA screening, which was disappointing. And I don't know if you know, but like a lot of these task forces actually don't have any prostate cancer, experts on it. They are a group of varied individuals, epidemiologists, researchers and stuff that kind of come together to make these recommendations. And the behind this was that patients were being overdiagnosed and overtreated for their prostate cancer and then would not have a benefit. And what was disappointing was that the Canadian task force didn't really do anything differently. They just adopted the American recommendations in 2014. So they said there should not be any screening at all. And we are still, I think, dealing with the consequences of this recommendation. They did backtrack. So in 2017, I think in the US, 2017, 2018, they decided that, listen, you could, in men with life expectancy of greater than 10 years, have a evidence-based informed discussion about PSA screening talking about harms and risks and benefits. And that was a little after a number of years, right? And then it took, and still taking time to kind of change back to this of screening versus not screening. When they looked at the study, before I go back to this, when they looked at the studies about how the impact was for that US recommendation, there was sort of half and half. Some practitioners were still doing the screening, and then half of them stopped screening altogether. So why did they recommend against screening? So there's no overall mortality reduction, although cancer-specific mortality does decrease by 20% by screening for PSAs, and that's like 2 big studies. And obviously there are harms from doing screening. So the workup, you know, you can have the biopsies can be associated with infection. In some cases, we've had a couple of patients who had actually septicemia, bleeding, pain, psychological trauma from the biopsies. It's very, you know, uncomfortable, obviously. Some patients have had urinary obstruction after biopsies. I mean, they're not without some amount of risk. There's also the harm of overdiagnosis. So you're diagnosing low risk patients, which causes anxiety, psychological stressors. And some of these diagnoses that we make with people with prostate cancer actually don't have any impact in the lifespan of that patient. We can overtreat. And obviously treatment, no matter what anybody tells you, I tell this to my patients, there's always going to be side effects and complications from treatment. If they say there's no side effects and complications, they're trying to sell you something. So both surgery and radiation have very, very different side effects and complications, and now in the acute and long-term settings, but they do impact people's quality of life. We don't take that lightly. The false positive PSA happens. We have a number of benign causes of elevated PSA, and the anxiety is not a small amount of anxiety. Cancer, where it comes to patients, it is anxiety provoking. So the problem is now, who do we screen? So there's obvious ones that we know people have a higher risk of having clinically significant prostate cancer. Those are Black men, patients with a positive family history, patients who are BRCA1 and 2 positive, and people have Lynch syndrome. So these people should be screened and screened early. The problem is now that we're seeing, which anecdotally I have noted in my practice, and obviously with my colleagues as well, is that there is a consequence to not screening. That people with metastatic disease and more serious high-grade disease is increasing. And so this graph obviously starts a little bit earlier in the States, and stage 4 is increasing in the US following this recommendation by the task force. And unfortunately, we're also seeing it here. The problem with stage 4 prostate cancer is that it's not, while it is not curable, right? We can absolutely treat stage 4 metastatic prostate cancer, but it is not curable. And by that recommendation of not screening, that helps with the low risk people who don't have clinically significant disease, but at the risk of missing or delaying treatment in intermediate and high risk patients, therefore increasing our ability to cure people and also having to treat people with metastatic disease going forward. So do we have a middle ground? Can we have a middle ground where we can do a balance of understanding, yes, there are harms of screening, but there are also benefits. We can diagnose people earlier and cure them, as opposed to waiting until they have metastatic disease. And what we forget is that there are costs to stage 4 incurable prostate cancer. There are the side effects and complications from the treatments that we give people, which are long-term now because they're not curable. There's obviously mortality, and there's a societal impact, the cost of treatment, hospital stays, loss of productivity. These things would have not been seen had we been able to intervene earlier and try to cure people earlier. So let's talk about shared decision-making, which I call smart screening. These are a number of questions that you can ask yourself, okay, when you're faced with somebody in front of you, when is a good time to kind of start it? And when is it good time to stop it? And should you be doing something differently based on your patient characteristics? So when to begin screening? So those high-risk groups before, I advocate for doing a PSA at age 40, age 45, depending on the patient. Age 45 for somebody with a positive family history, but Black, BRCA positive, Lynch syndrome should have one baseline PSA at age 40. And if it's fine, then there's no reason why you can't repeat at age 45. From that point, though, those high-risk groups should be screened every 1 to 2 years. So that's assessing the risk part, race, age, family history. When we're doing a risk-adjusted approach, so the average risk person, the guy sitting in front of you right now who's 50, can start doing PSAs if their life expectancy is going to be greater than 10 years. So if you have a vasculopath or somebody who has uncontrolled coronary artery disease, this is not maybe something you need to concentrate on. And obviously the high-risk populations I just spoke about. The frequency of screening is difficult in terms of trying to get some sort of idea evidence-based wise about how frequent. We know that one PSA, not surprisingly, is not enough. Data is very clear on that. And most of the studies suggest every 1 to 2 years based on your PSA trend. The life expectancy thing of the less than 10 years is not surprising. And then typically we tell people to stop screening at age 50, 75. Although I would tell you that some of my age 75 to 80-year-olds are far more healthier than my age 50 to 60-year-olds. That also might change as we go forward. And just to, I run into this all the time that people are like, well, the PSA is 18, but the patient's on Avodart or Proscar, and that really means the PSA is double that. So don't forget. Any questions so far? I'm doing an awful lot of talking. You can always interrupt me. Just raise your hand. I can't see your hand, Shanna. I'm going to ask you to look for hands.
No hands so far.
Okay. So that's when we should screen. When should you refer the patient for further investigation? So typically when the PSA is over 4, when you have a rise of PSA on the Avodart or Proscar, and an abnormal DRE, which obviously in COVID we haven't been able to do very often. Theoretically, that's what we should do. And the typical pathway is referral to urology. But I'm going to suggest that really there's a way that we can mitigate some of the anxiety that patients experience by going through a rapid diagnostic assessment program like we have here. And DAPs are shown to reduce anxiety. You have rapid access to the biopsy, diagnosis, and then access to the specialist and then the treatment planning so patients have a plan. On that map there shows some of the DAPs that are available in this area. We have one here. And the other way you can figure out whether somebody needs to be seen or not is by putting their particulars in the risk calculators. There's a number of them available on the internet that help you kind of decide on whether to push forward for further investigation or not. There's a lot of tools that are available now, and some of them are actually even more finessey with additional information and stuff. And the other thing, which is probably more in the realm of the specialists and stuff, but we are getting better. Like now it's not just PSAs, that you can use MRI as one of the first steps in diagnosis instead of biopsy. And so if you have somebody who has a normal MRI in the setting of a relatively elevated PSA, you can maybe delay biopsy going forward a bit while we monitor the PSAs. So the MRI actually is now first go in some settings. You have to obviously have the expertise for MRI. This MRI cannot be done in just any center. There are special sequences that they need to do MRI prostate, and the expertise obviously as well. So these ones we typically try to order here. And having smart screening gives you a diagnosis of prostate cancer. What I have to assure you of is that we also do smart treatment in Canada, that we use risk stratification for prostate cancer patients to help us guide what treatments that we would offer people if there's any treatments. And so we do, from the digital rectal exam, the PSA and the Gleason score, put people into risk groups: low risk, middle risk, and high risk. And there's more finessey ones in between those ones. And that helps us decide on what to do next with patients. So in low risk prostate cancer, active surveillance is the standard of care. It does reduce unnecessary treatment in low risk patients who can get behind just so-called watching their PSAs and biopsies as opposed to doing treatment. And this is what is different in Canada versus what it was in the States, that Canada has been at the forefront of active surveillance. We have Lori Klotz, who has the Order of Canada for active surveillance at Sunnybrook. This is like a Toronto baby that we have pushed through in the prostate cancer world, that active surveillance is safe, that we know that people who get treated now when they get diagnosed with low risk prostate cancer versus later when they get upgraded, their outcomes would have been the same. And by doing active surveillance, you don't give people side effects and complications from their treatment. Unfortunately, we can't do a lot for the psychological stress of having prostate cancer, but it certainly mitigates that. In the States, it is different, was different back then when the recommendation was made. Everybody theoretically would get treated, even if they had a little tiny little molecule of Gleason something disease, Gleason 6 disease, because people in the States, not surprisingly, do make money from treatment. And for radiation, they got paid for every little treatment that they gave. So a lot of people got treated. That is not the same thing in Canada. In Canada, we've always been smarter screening, smarter treatment. And so the recommendation that was made by the Canadian Task Force was not taking into account the Canadian context at all, really, in my mind. But we are a big active surveillance country. And we save money with active surveillance. We save probably that big number with lots of zeros a year by watching people. That is including doing PSAs and including doing biopsies, and probably save less now that we do MRIs more frequently in patients. So this is a radiation slide, obviously, because surgery you could theoretically do all the way across the board. But we make our decisions based on treatment and risk group. And so what I offer people, which have different side effects, differs and escalates when they have more aggressive disease. And this probably is something that you don't realize on any given day, that I picked the wrong specialty when it came to technological advances, that I totally, absolutely do not do the same thing when I started my training, when we used to use grease pencils and x-rays, versus what I do now when the algorithms and the imaging and the software and the hardware all help to make our accuracy better in radiation treatment, but more importantly, less side effects and complications, because we can tailor and carve off of bladder, bowel, and rectum. The radiation treatment that people get in 2022 is not even close to what they had even 5 years ago. We keep getting better and better. The data and evidence that we have with studies show, we can do, instead 20 fractions, 5 fractions now. It is more convenient, more precise, and more effective. And the surgeons will tell you with robots and everything, it's a similar. This is my life, my brachytherapy. the radiation source that we have in the OR downstairs allows us to give a very high dose, which is very important for prostate cancer, actually, because prostate cancer does require a higher dose to be killed. And we are limited by external beam treatment or X-ray treatment because of the normal structures that pass through, that the beam has to pass through to get to where we want to go, even if it's a 4 millimeter accuracy. Brachytherapy, I don't have those same concerns as much because I can go inside the prostate itself. And so we can give a higher dose to where we want it to go, prostate, and then the dose falls off in millimeters, so the impact on your bladder, your bowel, and your rectum is much, much, much less. The treatment time is less, the recovery time is less. That's our beautiful OR that we have downstairs. And we've moved now from everybody, when they think of brachytherapy, they think of the radioactive iodine seeds, which is a permanent seed implant. It gives radiation over weeks to months. And now we've moved to high dose rate brachytherapy, which gives radiation over seconds, really. And the advantage is that what I plan and what I see is what I get, because I do that all in one sitting, as opposed to multi-step processes with the other one. LDR brachytherapy is falling out of use more because low risk patients, which is an indication for it, all have active surveillance. The government does cover LDR brachytherapy for favorable middle risk prostate cancer, but it is done so infrequently now that we really send all of our patients to Sunnybrook. And we can do 2 fractions of high dose rate brachytherapy, which mimics the low dose rate instead, which is what we do here. I will tell you that I think I've treated maybe 2 people in the past 5 years with low risk prostate cancer. Thankfully, active surveillance is what's done. Those 2 patients couldn't psychologically handle not being treated, which does happen, though infrequently. And for external beam treatment, it has also evolved. We have machines and software and things. We do CAT scans and MRIs for planning. Sometimes even PET scans now I add to the gamut. And the precision of 4 and 6 millimeter accuracy helps us to give what we now do on the right, which is stereotactic radiation treatment, using the same kind of setups and thoughts that we do for stereotactic radiosurgery. We can hit like a 2 millimeter thing in the brain. The prostate is way easier, it's way bigger. But instead of doing 20 treatments on your left, now we can do 5 treatments on the right. More convenient, extreme precision, I tell patients. Similar side effects and complications. And here in Oshawa, we add another special thing for SBRT where we put a rectal spacer gel between the prostate and the rectum so that patients will get less rectal side effects. So survivorship in terms of after treatment, the precision and efficacy is there, but we're trying to minimize also the side effects and complications later for patients. Oh my gosh, we're at summary already. It's 12:30. So PSA screening does reduce prostate cancer mortality. It does. We have evidence that it does. Anecdotally, I think it does too, but we have evidence that it does. But what we also have to understand is by not screening patients, there are potential consequences that are not necessarily good ones. By favoring not overdiagnosing low-risk patients who don't have clinically significant prostate cancer, we are missing or delaying diagnosis of patients with clinically significant prostate cancer, potentially losing the window for cure. And as I said before, metastatic disease, while treatable, is not curable, does have its own side effects and complications and expensive treatments. My other plug is that referral to a prostate DAP does reduce anxiety, and we have one available here to patients. And we're going to be using MRI to improve the screening so we can reduce biopsies and the potential side effects and consequences of biopsies. And with MRIs, we'll be able to find less clinically significant prostate cancer and more clinically significant prostate cancer. we are the active surveillance, center of the world, and it does avoid unnecessary treatment if you can get past the psychological stress of having cancer and not doing something active about it. And since I'm a radiation oncologist, I can only speak to radiation, but we are getting better every day in terms of our treatment. That if we do have to treat people, we are hoping that they get cured, great, but they're also going to have less side effects and complications going forward. Do I have any questions? It's awfully quiet out there.
You just gave the most informative presentation ever, Dr. Lee.
Sometimes it's something I'm quite passionate about.
That was a fantastic presentation. Any questions? Oh, good. Yes. Vahid.
Hello.
Hello, I'm from Thunder Bay, research fellow. Very informative, very phenomenal talk. Thank you so much for putting all this information together. Just one question about the cutoff point for prostate cancer, about 0.4. Does it apply to all ages, or you think that it's gonna be different? We could
adjust. You mean 4.0? There are age, yeah. There are age. I didn't put that on. There are age kind of cutoffs and stuff, but like it's easier to remember 4.0 than it is for anything else. And I tell patients like one PSA 4.0. I never, it doesn't make me jump the gun. It's trend is important. So if you have an elevated PSA, I would do a PSA in 3 months and see where we're at and get more points on the curve. I have seen so many people that just, had the one and then didn't have it again until they had clinically significant prostate cancer with other things. So having more points on the curve helps. It's also, difficult because patients have to pay for the PSA, right? It's still $30. That would be, I jokingly say, the only benefit of having prostate cancer is that you don't have to pay for your PSAs anymore. But, you don't want to do it too often, but, often enough.
So if you find someone, for example, a bit above 4 and just do another one, repeat the test.
In 6 months, yeah, 6 months.
6 months, and then what are you looking at the 6 month doubling time or whatever? What the trend? What is you looking for?
Yeah. So if the PSA is still persistently elevated, so that's not like a infection or inflammation, whatever, then it's worth seeing whether they can get referred to a urologist or a prostate DAP and have a conversation about whether to biopsy or not, or what other investigations can be done. I would say that because MR access is difficult and MRI prostate expertise is not everywhere, that it's hard to do MRIs in advance because you may not know what to make of it. And I would put it to the prostate DAP or a urologist to kind of move forward on it.
And would you recommend to put patient on antibiotic in this during this 6 months? No.
No.
Great, amazing. Thank you so much. Appreciate it.
No worries.
Dr. Bohar.
I wondered if there was any use, like for family physicians. I've had patients request like a prostate ultrasound rather than doing a DRE. What would you say about that?
I would say no. Yeah, they're not like I don't know why would you like, because a prostate ultrasound is still a transrectal ultrasound. I would rather have a DR. Okay, not me specifically, but I think a DRE is better use of resources, shall we say. And then like an ultrasound is not fantastic. I would do an MRI anyway. Like sometimes you can see lesions on the ultrasound, but then what are you going to do with them? They have to have a biopsy anyway and have another ultrasound transrectally. So
thank you.
No, that everybody liked COVID because we were doing things virtually and I couldn't do a digital rectal exam. but they at least had a rectal exam when they had the biopsy, which was helpful. And I mean, I tell patients, like, they're like, well, why, you know, you did the DRE and you didn't feel anything. Why do you still do it? And yes, my finger is not good in terms of finding microscopic stuff, but I have felt very abnormal DREs in the setting of a normal PSA. So it happens. It's still one of the things that we do. There are still PSA non-producers or less producers. I've had patients with metastatic disease and their PSA was 2. So it can't be just, we can't just look at PSA alone. But it is a start. And maybe as we get more access to MRI and these sort of things, that it'll help us tailor our screening a little bit better.
Oh, one more question. This is Vahid. So, and about the free to total PSA, how does it help, or any help for the ratio?
It does. Yeah, it does. I have to say it right because I always get the wrong order of things. But when you look at the results that come back, it reads as abnormal, and it's like you have. I'm not going to say it right. When you have prostate cancer, there's more free PSA than bound PSA, and that's why that number helps when a non-prostate patient.
Great.
I probably said it wrong.
Kate, go ahead.
Thanks for the talk. I'm in Port Hope, so you see a number of my patients, Dr. Lee. Thanks for that.
Oh, my pleasure.
If somebody's doing PSA screening, and I have some patients that are still choosing to do it despite having not been certain what to recommend over the last couple of years, and we start them on something like Avodart for BPH symptoms, and their PSA doesn't drop by half, is that concerning?
I would be concerned.
Even if it's in the normal range and was in the normal range previously, but now hasn't halved.
Like I would still, I'm concerned. Like I would be concerned. I wouldn't necessarily do anything about it, but it would be somebody I would follow more closely.
Okay.
And patients, like, uniformly never realized that their PSA was actually doubled that. Like they were like, well, why are you so concerned? Like my PSA is only 12. I'm like, well, your PSA is actually 24, and that makes you high risk because anything over 20 is high risk. And they're like, what? I have high risk prostate cancer? Yeah. Like they never know that, right? They think, oh, it's okay. You know, my prostate's not so high. My PSA is not so high. But it does give me pause, right? Because it should drop the PSA in half, except for, I guess, in that case, you know, if it's low enough, then it's just all normal stuff, and then you don't have to worry. This is why I try to do more things like, you know, Flomax and things that help with urination, as opposed to things that are actually going to change PSA. I would favor that. I would favor that more, and then trying to give them something that's actually going to mitigate that. There is anecdotal stuff and some small studies showing that, you know, that the Proscars and Avodarts of the world, the 5-alpha reductase inhibitors, they will hold off the more clinically insignificant or the lower risk disease in favor of letting the more higher risk disease grow. I've seen it, and small studies have shown it, but that's why those 2 drugs kind of give me pause a bit. But I never have to prescribe them. So, well, not never. I rarely prescribe them
unless somebody's progressing on Avodart, and then we need to sort of move to the next step in terms of managing their symptoms. And I would say I'm only adding it if their PSA is in the normal range, which is why I'm struggling to know what to do if I've added it and their PSA is in the normal range, but then doesn't drop significantly. Like if it's a 3.8 and they don't go down to a 1.6, should I be worried?
No, like I wouldn't, like if it's all normal,
Okay.
not cancer, then it shouldn't, like you shouldn't have as
Yeah, I
much of
mean,
an
that's-
effect.
As a
Right.
family doc, that's most of what I see, so.
Yeah, that's good. So trying to find the stupid thing here. For age ranges, so for 40 to 49 it says 0 to 2.5, 50 to 59, 0 to 3.5, 60 to 69, 0 to 4.5 in terms of age. I just remember 4 myself. And I have had patients die of metastatic prostate cancer at age 45, so I am those people we would never gotten on screening unless they had a baseline PSA at 40 or 45. Any other questions while I'm trying to find the free stupid ratio thing? It's going to bug me. Also a benefit of virtual, I can look things up while I'm talking to you. I'm very lucky because by the time I usually see people, they have a diagnosis of prostate cancer, so I never have to worry about free to total.
Dr. Lee, while you're looking for that, maybe I'll just a little bit of housekeeping. I'll just say that we'll be sending out certificates for the participants. So please make sure your full name is in displayed on the Teams chat. If we don't have your full name, we can't make out your certificate effectively. So put your name in the chat so we know who to make that out to. And we really appreciate everybody's time coming to listen. And Dr. Lee, thank you so much for this amazing talk. It was really helpful and informative, I think, for lots of people. Any final words, Dr. Lee, before we end?
Smart screening, smart treatment.
Absolutely. Thank you so much, everyone. Have a great afternoon.
Have a great day, everybody.
Thank you.
Have a great day. Thank you. Bye-bye.